Well, good morning, good afternoon, and good evening for those of you joining us from everywhere. Thank you so much for being here with all of us today. It's truly exciting. Welcome to the London Global Cancer Week NCI session, where we'll be highlighting the contributions of community health workers and patient navigators in the cancer continuum and research in LMICs. We'll be discussing practical examples and opportunities for engagement. And I'm quickly going to share my screen for all of you. Okay. Great. I am Hawa Kamara, and along with some of my colleagues here on the screen, we have a pretty great session for you today. So quickly going over the agenda for our call, our session, we'll briefly introduce what we'll be going over today, which includes a Slido function and a word cloud. So get ready for that. Then we'll have about 45 minutes dedicated to 3 great presentations, which will run about 15 minutes each. The first one will be by Dr. Rebecca Ocampo from Costa Rica. Our next set of presentations will come from a team, a US and India team led by Dr. Suparna Kanungo, Dr. Gaurav Kumar, and Chinmay Madal. And finally, we'll have our colleague from Rwanda, Dr. Theonis Maniragaba. We'll then have sufficient amount of time for a Q&A session, which will be moderated by my colleagues, Francine Baker and Jack Murphy, and we'll end with closing. Just a few logistics for you all. Please note that this session is being recorded and will be made available after the event. We also wanted to make you aware that we do have simultaneous translation available in Bengali, in French, and in Spanish. So we want to direct you to the interpretation icon at the bottom of your screen, of your Zoom screen, which will allow you to select your language of preference. And finally, please submit any questions you have or comments as well in the chat box also below at the bottom of your screen for our panelists as well as organizers of this session. So as mentioned briefly, we are using the Slido poll today, and we want to give you sufficient amount of time to open up a browser, either on your computer or your phone, and type in www.slido.com. So you will type in the code that is on the screen, which I'm sharing at the moment. I'm hoping you can see that for us. And we are hoping that you can answer our initial question, and please note that all of our responses are anonymous. So we'll start with our first question, which will look like a word cloud. And that question is, which words come to mind when you think about community health workers or patient navigators and community-based participatory research in cancer? So we'll give about maybe about a minute for all of you to respond. And please note that this Slido poll will be open throughout the remainder, at least, of our initial presentations. And we'll also use some of those responses to target or direct our conversations. We're seeing a few here already. Foundational, essential, respect. That's amazing. Equity. Essential. It's wonderful. Essential and overlooked. That's great. So we'll give it a few more seconds. And thank you to all of you for joining again. And for those of you just joining us, please join Slido. The hashtag is provided LGCW 2023 in the passcode on the screen. And at the moment, we are answering this initial question, which will look like this word cloud that you're seeing on the screen. Wonderful. Advocates, underpaid, that's a great one. Equity keeps coming back, equity and essential. Wonderful. So we will keep this word cloud as noted open for you. But without further ado, we'll start our presentations. So our first one is from Dr. Rebecca Ocampo from Costa Rica, and her presentation is titled Cancer Care and LMICs, Bridging Gaps Through Community Health Workers and Patient Navigators, Insights, Examples, and Opportunities. Dr. Ocampo is a highly experienced medical doctor with a remarkable 18-year career in clinical research. She started her journey when she joined the clinical staff at the Agencia Costarricense de Investigaciones Biomédicas, trying my really basic Spanish accent, a pioneering Costa Rican organization deeply involved in clinical cancer prevention research. Currently, she is the local principal investigator for a study examining the prevalence and persistence of anal infection by the human papillomavirus and associated diseases among women. Dr. Ocampo, I pass it on to you. Thank you.
Muchas gracias. Quería confirmar que todos me pueden escuchar para empezar a compartir mi presentación.
You want to
Bueno, buenos días, buenas tardes y buenas noches a todos. Primero quisiera darle un agradecimiento al equipo organizador de esta importante sesión por invitarme a participar. Como bien lo indicó nuestra coanfitriona, el tema que voy a tocar hoy es la atención de cáncer en los países de ingresos bajos y medianos, cerrando brechas a través de los trabajadores de salud comunitarios y los navegadores de pacientes. Vamos a tocar un poco de perspectivas, ejemplos y oportunidades. La carga global del cáncer ha sido considerable y no es ningún secreto que la COVID-19 ha exacerbado aún más los desafíos, especialmente en estos entornos con recursos limitados. Por ejemplo, se dificultó el diagnóstico temprano del cáncer, el tratamiento y el seguimiento a pacientes y asimismo disminuyeron las campañas de prevención, algo que se está evidenciando con el aumento en los casos de la detección tardía. Vamos a explorar cómo los trabajadores de salud comunitarios y los navegadores de pacientes están dando un paso adelante para marcar la diferencia en el cáncer continuo. Antes de adentrarnos en los detalles, es importante que aclaremos quiénes son los trabajadores comunitarios y los navegadores de pacientes. Los navegadores de pacientes son individuos capacitados para ayudar a las personas a lo largo de todo el cáncer continuum, actuando como guías para los pacientes que navegan por el complejo sistema de atención médica, ayudándolos a acceder al cuidado y apoyo que necesitan. Los trabajadores comunitarios de salud suelen ser miembros locales de una comunidad que están capacitados para ofrecer servicios de salud básicos, educación sobre salud y apoyo. Poseen un profundo entendimiento de la experiencia de la vida en su comunidad y esto los hace especialmente calificados para abordar los determinantes sociales y conductuales de la salud. Ahora exploremos los roles fundamentales desempeñados por los trabajadores de salud comunitarios y los navegadores de pacientes en el cáncer continuo. Estos individuos sirven como puente entre las comunidades y los sistemas de atención médica, contribuyendo a la detención temprana, al apoyo al paciente, la educación y el mejor acceso al cuidado del cáncer. Su impacto es particularmente significativo al cerrar brechas en el acceso a la atención médica, brindar apoyo y mejorar los resultados para las personas que enfrentan el cáncer. Adentrándonos un poco más en cómo actúan en las diferentes etapas del cáncer continuum, es importante decir que tienen mucha participación en lo que a prevención refiere. ¿Por qué? Porque brindan esa educación a la comunidad, generan conciencia sobre los factores de riesgo del cáncer, proporcionan información sobre medidas preventivas, enfatizan la importancia de la detección temprana, orientan sobre estilos de vida saludables, ofrecen consejos sobre la adopción de estilos de vida saludables y promoviendo dietas equilibradas, ejercicio regular, desalentando el consumo del tabaco y del alcohol. Si ya nos metemos en lo que es detección temprana, pues los trabajadores de salud comunitarios organizan tamizajes de salud en la comunidad, facilitan la detección temprana de signos de cáncer, aseguran el acceso a los servicios diagnósticos oportunos y los navegadores del paciente guían a las personas a través de los procesos de tamizaje, abordan temores, incertidumbres, garantizan el cumplimiento de los protocolos. En cuanto al diagnóstico, facilitan el acceso a la atención médica. Los trabajadores de salud comunitarios ayudan a navegar en el sistema de atención médica, apoyan el acceso a los servicios diagnósticos y aseguran un seguimiento oportuno de todas las anomalías que se detectan durante el periodo de tamizaje. Los navegadores de pacientes en la parte diagnóstica brindan apoyo emocional, ofrecen un apoyo durante la fase diagnóstica, ayudan a los pacientes a entender su diagnóstico, facilitan la comunicación con los proveedores de atención médica. En cuanto al tratamiento, pues los trabajadores de salud comunitarios garantizan las adherencias al proporcionar información, abordan barreras financieras, culturales, ofrecen asistencia práctica, defensa del paciente, porque los navegadores de pacientes abogan por los pacientes dentro del sistema de atención médica, ayudan a los pacientes a entender las opciones de tratamiento, asisten en el manejo de efectos secundarios y en la toma de decisiones médicas. En cuanto a supervivencia, tienen ese apoyo post-tratamiento, los trabajadores comunitarios y los navegadores de pacientes contribuyen al apoyo post-tratamiento, atienden las necesidades específicas de los sobrevivientes de cáncer, promueven un estilo de vida saludable, ayudan en esa transición del regreso que tienen los pacientes a la vida normal. Los navegadores ayudan en la coordinación de citas de seguimiento, aseguran que los sobrevivientes de cáncer reciban la atención médica continua y el apoyo. En cuanto a los cuidados al final de la vida, apoyo en los cuidados paliativos, los navegadores de pacientes brindan un apoyo invaluable en la coordinación de los servicios de cuidados paliativos y ofrecen apoyo emocional a los pacientes y sus familias durante momentos difíciles. Sin lugar a duda podemos ver que son personas fundamentales, ¿verdad? En el cáncer continuum, que sin ellos no tendríamos, las cosas no estarían bien. Hay mucha evidencia científica que ha demostrado que ellos hacen diferencia en estas diferentes etapas del cáncer continuum. Y es por eso que ahora yo les quiero compartir un ejemplo de nuestro país, de Costa Rica. Para la organización en la que yo trabajo, así FUNIN es un centro de investigación dedicado al cáncer. Tenemos una larga colaboración con el NCI durante más de 28 años. Hemos llevado a cabo aproximadamente 15 estudios epidemiológicos a gran escala. 6 de ellos son ensayos clínicos relacionados de fase 3, relacionados con la eficacia de las vacunas del virus del papiloma humano para prevenir el cáncer del cuello cervical. A lo largo de estos años hemos inscrito aproximadamente 70,000 participantes y esto no hubiera sido posible sin la gran contribución de aproximadamente 400 trabajadores de campo que en nuestra organización desempeñan un doble papel. Y les digo que desempeñan un doble papel porque ellos son tanto trabajadores de salud comunitarios como navegadores de pacientes. Siempre hemos tenido una tasa de retención de participantes por encima del 95% y esto es algo muy importante. Creemos que el suceso de nuestros trabajadores de campo empieza desde que los contratamos. ¿Por qué? Porque nuestros trabajadores antes de iniciar a trabajar con nosotros son entrevistados se les realiza una entrevista por competencias, posteriormente les realizamos pruebas psicológicas, nos aseguramos que nuestro equipo de trabajadores de campo sea multidisciplinario, porque eso enriquece más el trabajo de la organización. Entonces tenemos de diferentes ramas, de sociología, de psicología, enfermeros, técnicos de atención primaria en salud. Antes de que inicien sus labores y vayan al campo, reciben un entrenamiento sumamente exhaustivo por personas claves de la organización, por expertos en los temas. También nos aseguramos que reciban un entrenamiento continuo y actualización. Para nosotros es muy importante enviarlos al campo ya sensibilizados y empoderados para que ellos puedan impactar positivamente a las comunidades donde nosotros trabajamos. Adicionalmente, les hacemos una evaluación de desempeño cuando ellos entran a los 3 meses y continuamente les realizamos evaluación de desempeño para romper esas brechas que a ellos les puedan surgir durante el campo. Con esta diapositiva yo les quiero demostrar por qué hemos sido exitosos en nuestro trabajo de campo. Como ustedes pueden ver, nuestros trabajadores de campo se hacen parte de la comunidad, tienen empatía, las personas confían en ellos, que es lo más importante. Si bien es cierto, no todo es perfecto, hemos enfrentado retos, pero siempre tratamos de solucionarlos de la mejor manera, nos reunimos continuamente con ellos, ellos tienen las puertas abiertas con los investigadores, con los médicos para aclarar dudas, se hacen parte de esa comunidad, porque no solo andamos buscando de casa en casa reclutar personas, andamos buscando personas para cambiarles la vida, para impactar positivamente, para poder formar parte de cambios en nuestras políticas de salud y en la salud pública. Entonces, todas estas diapositivas demuestran cómo nosotros y nuestros trabajadores de campo estamos realmente involucrados, que eso es algo sumamente importante, ¿verdad? Primero hay que generar la confianza, que las personas sientan que van a ser parte de algo importante, que su colaboración va a poder cambiar la vida de muchas personas, no solo en nuestro país, sino de muchas personas alrededor del mundo. Como consideraciones finales, yo quisiera decirles que la integración efectiva de los trabajadores de campo y de los navegadores de pacientes en la atención del cáncer no solo mejoran el acceso y la calidad de la atención, sino que también contribuyen a cerrar las brechas entre la investigación y la práctica. La implementación de programas de formación integral de trabajadores de salud comunitarios y navegadores de pacientes garantizan que ellos tengan el conocimiento y las habilidades necesarias para apoyar de manera efectiva a los pacientes con cáncer y navegar por este sistema de atención médica. Las asociaciones entre organizaciones de atención médica, entre agencias gubernamentales y no gubernamentales, fortalecen el impacto de los trabajadores de campo y de los navegadores de pacientes. Mis otros compañeros panelistas cuentan con una amplia experiencia en el campo y están aquí para compartir sus puntos de vista, sus experiencias únicas, y esperamos aprender de estas experiencias para obtener una mejor comprensión de cómo estos trabajadores de salud comunitarios y navegadores de pacientes están contribuyendo a mejorar la atención del cáncer en los países de ingresos bajos y medianos. Al final de esta importante sesión, los organizadores y nosotros los panelistas esperamos haber cumplido con los objetivos de aprendizaje y demostrar el gran valor que tienen estas personas en el cáncer continuum y identificar estrategias que podemos hacer para mejorar y poder enfrentar los retos que tenemos actualmente. Muchas gracias. Los invito a visitar mi país y, por supuesto, a visitar la Agencia Costarricense de Investigaciones Biomédicas.
Thank you so much, Rebecca, for such a great presentation, allowing to set the scene and also highlighting the importance of community health workers, not only globally, but also providing the example of Costa Rica. So that's very much appreciated. So just before heading to the next presentation, just wanted to quickly go back to the Slido poll and make sure that those of you who have joined us during the Dr. Ocampo's presentation are also aware of the Slido poll happening. Again, the hashtag provided LGCW 2023 and the passcode, and we would love to hear from all of you. So our next presentation comes from one of our great teams, and will highlight the work that is happening in India. So Dr. Suparna Kanungo will lead this presentation, and she is an associate professor in the College of Nursing at the Medical University of South Carolina, MUSC. She is also the director of global health at the college. She started her career as a cancer research scientist in cell biology, genetics, and biomarkers at Case Western Reserve University and transitioned to a public health scientist at MUSC. Chinmay Mandal is a community health worker under the NIH NCI R21 grant on implementation of home-based palliative care in resource-limited settings, and will speak to us about his own experience, and we're very excited about that. And finally, we have Dr. Gaurav Kumar, who is presently working as a consultant in the Department of Palliative Care and Cyto-Oncology at Tata Medical Center. And Dr. Kumar has completed his MBBS and MD from SCB Medical College and Hospital in Cuttack, Odisha. And they'll be highlighting home-based palliative care facilitated by community health workers, experiences and lessons learned. So Parna.
Thank you. Thank you so much. And let me just share my screen to make sure that we can see everything. Hold on. Can everybody see my screen yet? No?
Not yet.
All right, let's see where we went. Okay. Sorry about this. I'm trying to. Okay. Share. Can you share? Can you see now?
No, we're still not able to see your screen. Okay. You can see it now.
See it now? Okay.
Yes. Okay.
All right. So welcome everyone, and greetings wherever you are in this world, in the world. And I am so honored to be able to present our work in India. And thank you also the organizing committee for inviting us to be able to present here. So this is a US-India collaborative project. And along with me, as you know, we have our community health worker, Mr. Chinmay, and our site investigator and clinical PI, Dr. Gaurav Kumar, present this work. And I am really excited to be able to do this because it was such a, we had a lot of experiences that we learned from this. And before I go, we have the research team who are in MUSC and Tata, and I really want to thank them. Without them, it was impossible to do this amount of work. So as you all know, the global need for palliative care is huge. There are like 40 million people who need palliative care and end-of-life care, but only 10% receive it. And 80% of these patients who need these services are in limited resource countries. So the project that we did is to improve palliative care services. That was the purpose for cancer patients in rural areas outside of Kolkata, India. And Kolkata is situated in the state of West Bengal, India. So we had two aims for this project. So this was implementation of home-based palliative care in limited resource settings. So, in the low resource countries, as you'll see later on in the pictures, I'll show you some pictures where you'll see how, where our patients used to reside and how difficult it is for them to be able to come to the cancer center to get the treatment and the care. So like anything that we can do to reach them at their places, at their homes is wonderful. And hence the community health workers, our community health workers were literally like they were godsend, and they were so important and played such an important role in facilitating this home-based palliative care. So the two aims of this project, the first aim was to evaluate the implementation of the palliative care program, and it was based on the World Health Organization's palliative care toolkit. And our aim too was to evaluate the outcomes of the palliative care intervention compared to the usual care. So as I mentioned before, our study setting is the Tata Medical Center, and our population was adult cancer patients in the palliative care department, and who belonged, who were from the residing in the 24th Parganas, we say, that's a region in the West Bengal, India, that was outside of Kolkata, and also some in and around Kolkata as well. So the very first thing that we did in order to be able to deliver the home-based palliative care facilitated by our community health workers, we had to recruit our community health workers and train them. So our community health workers, as you heard from Dr. Campo's speech, is that they are like embedded in the community and they are members of the community. So that's how we recruited some of our 6 community health workers. And then we trained them very robustly using didactic, clinical shadowing, case studies, role plays, field training. It was like a month-long training to start with. And then also they had like ongoing training where they were associated with the cancer center and were working in the cancer center to be able to gain all the experiences together with their work at the field, which was hugely impactful, as I'm sure Chinmay would mention some of it. So our model was this hub and spoke model where you see the cancer center was in the middle and the rural communities were on the outskirts, and our community health workers formed that bridge between the cancer center and the rural communities and in the patients and their families. We had 90 participants. 45 of them were in our PAL care intervention group and 45 in our control or usual care group. So the intervention group received the intervention and the usual care received, just basic palliative care services, which were given from the cancer center. So it was a 6-month intervention. And it was developed on the basis of the WHO toolkit. And what was the role of our community health workers? They would visit patient and family 1 time weekly or even more as needed, facilitating basic palliative care. Then they would serve as the link between the patient family and the cancer center, and they would link through telehealth between the cancer center oncologists and the patients in their homes, which the patients were really, really happy about. And then they would monitor pain and symptom control. They would educate patient family on disease and symptom management, and they would also help find community resources to help with the practical challenges, which was another huge help to the patients and their families in the rural communities, like arranging for transportation, insurance, nursing care, medication availability, and supporting spiritual support services. And finally, they would provide and facilitate emotional support for patient and family, which is a huge part of palliative care, as you all know. And our outcomes that we measured were palliative care needs, quality of life, symptom burden, and care experience. So the long-term goal of this project was to develop a feasible and effective and sustainable model for delivering home-based palliative care for cancer patients in rural underserved areas. So that was kind of the overview. And here are some pictures. So our patients used to live in these areas. So you can imagine, like in water bodies that they had to cross. And you can imagine how difficult is it for a palliative care patient to be living here and then trying to get to the cancer center to get treatment, or even anybody trying to reach them. So these navigators who were, or the community health workers who were embedded in the community played very important role. And these are also some of the pictures from our field visit when we visited, when the US investigators visited India. So And then this is a picture. I wanted to show you this picture. This is Dr. Gaurav and Chinmay here as well, who are trying to get onto a boat. And this is a river body that we had to go for 3 hours in order to reach the participant's house. So you can imagine how difficult and how rural some of these areas were, where our community health workers played a very important role to bring home-based palliative care. With that, I am going to hand it over to Chinmay Mandal, who is our community health worker and is just wonderful, and he would share his insights and experiences. Chinmay.
Good morning, good afternoon, and good evening, everybody. আমি চিন্ময় মণ্ডল, আমি ইন্ডিয়া থেকে বলছি। আমি টাটা মেডিকেল সেন্টারে প্যালিয়েটিভ পেশেন্টদের হোম বেসড কেয়ারের জন্য সপ্তাহে একদিন করে তাদের বাড়িতে গিয়ে দেখাশোনা করি। তো আমার প্রথম পেশেন্ট হচ্ছে আকিলা মোল্লা। উনি সুন্দরবন থেকে বিলং করেন। ওনার বাড়ি থেকে ক্যান্সার সেন্টারের দূরত্ব অনেকটাই বেশি, যোগাযোগ ব্যবস্থা অতটা ভালো নয়, আশেপাশে কোনো মেডিকেল ফ্যাসিলিটিসও নেই। তো আমি ওনার বাড়িতে গিয়ে ওনাকে সপ্তাহে একদিন দেখেছি। উনি একজন অ্যাডভান্স ক্যান্সারের পেশেন্ট ছিলেন। উনি মেটাস্ট্যাটিক অ্যাডিনোকার্সিনোমা সিএ ব্রেস্টের পেশেন্ট ছিলেন একজন। তো উনি খুবই গরিব ফ্যামিলি থেকে বিলং করেন। ওনারা বেসিক্যালি চাষবাস করেই জীবনযাপন করেন। তো আমি সপ্তাহে একদিন গিয়ে ওনার বাড়িতে ওনাকে দেখে আসতাম। তো আমি ওনার সিমটম ম্যানেজমেন্ট লাইক পেন এন্ড আদার সিমটমস সাইকোলজিক্যালি সাপোর্টও দিতাম। আর তাকে তার বাড়িতে গিয়ে কিভাবে সে লোকাল হেলথ কেয়ার প্রোভাইডারদের সাথে যোগাযোগ করে এবং কিভাবে সে ক্যান্সার সেন্টারের ডক্টরদের সাথে যোগাযোগ করে সেদিক দিয়ে আমি তাকে সাহায্য করতাম। তো উনি আমাদের এই প্যালিয়েটিভ কেয়ারের যে পরিষেবাটা পেয়ে উনি খুবই খুশি। তো
I apologize. I am so sorry. I just wanted to quickly, it seems like we're having some issues with the interpretation. So I really apologize for that. I wanted to see if our Bengali interpreter. Wonderful. Okay, so we apologize, everyone. Chinmay, I'm sorry. Would you be able to restart your presentation?
Good morning, good evening, good afternoon.
Thank you.
আমি চিন্ময় মণ্ডল, আমি ইন্ডিয়া থেকে বলছি। আমি একজন কমিউনিটি হেলথ ওয়ার্কার। টাটা মেডিকেল সেন্টারে আমি প্যালিয়েটিভ অ্যাডভান্স ক্যান্সার পেশেন্টদের বাড়িতে সাপ্তাহিক ভিত্তিক একদিন গিয়ে দেখাশোনা করি। তো আমি আমার প্রথম পেশেন্ট হচ্ছে আকিলা মোল্লা। উনি একজন অ্যাডভান্স ক্যান্সারের পেশেন্ট, অ্যাডিনোকার্সিনোমা মেটাস্ট্যাটিক সিএ ব্রেস্ট। তো আমি ওনার বাড়িতে গিয়ে ওনার সিমটম ম্যানেজমেন্ট, সাইকোলজিক্যালি সাপোর্ট এবং লোকাল হেলথ কেয়ার প্রোভাইডারদের সাথে কিভাবে উনি যোগাযোগ করতে পারবেন এবং কিভাবে উনি মেডিসিনটা খুব তাড়াতাড়ি সংগ্রহ করতে পারবেন সেই দিক দিয়ে আমি তাকে সাহায্য করেছি। তো উনি খুব গরিব ফ্যামিলি থেকে বিলং করেন। বেসিক্যালি ওনারা চাষবাস করে জীবনযাপন করেন। ওনাদের যে টাটা মেডিকেল সেন্টারে আসার জন্য, যে ক্যান্সার সেন্টারে আসার জন্য যে দূরত্বটা, সেটা হচ্ছে অনেক বেশি। ঠিকঠাক যোগাযোগ ব্যবস্থারও উন্নতি নেই। ঠিকঠাক তারা বাড়িতে কেয়ারও নিতে পারেন না। তো আমি সপ্তাহে একদিন গিয়ে ওনার বাড়িতে ওনাকে ঠিকঠাক ভাবে কেয়ার দিয়ে এসেছি। তো ওনারা টাটা মেডিকেল সেন্টারের এই প্যালিয়েটিভ কেয়ার যে পরিষেবাটা পেয়ে ওনারা খুবই খুশি। ওনার কোয়ালিটি অফ লাইফটাও ইমপ্রুভ হয়েছে। নেক্সট স্লাইড।
Next slide, please.
তো আমি কমিউনিটিতে গিয়ে যে চ্যালেঞ্জেস গুলো ফেস করেছি, সোশ্যাল চ্যালেঞ্জেস লাইক স্টিগমা। পেশেন্টের সাথে যখন আমি কথা বলতাম তখন পেশেন্ট আমার সাথে অতটা খোলাখুলি ভাবে কথা বলতেন না। তার ইমোশনাল স্পিরিচুয়াল কোনো কিছুই আমি ঠিকঠাক ভাবে জানতে পারতাম না। আর তার পারিবারিক সম্পর্ক ঠিক ছিল না, তিনি সবকিছুতে ভয় পেতেন, যে তিনি ইনসিকিউরিটিস ফিল করতেন যে তিনি কতদিন বাঁচবেন। তিনি একজনই ফ্যামিলিতে আর্নিং মেম্বার আছেন, তো তিনি যদি চলে যান, মারা যান, তাহলে তার ফ্যামিলির কি হবে। তো এমনকি আমি কমিউনিকেশন দিক থেকেও চ্যালেঞ্জেস ফেস করেছি পেশেন্ট আর পেশেন্টের কেয়ার গিভারের কাছ থেকে। আর পেশেন্ট নিজে থেকে কেয়ারও নিতে পারেন না ঠিকঠাক, সেদিক দিয়েও আমি চ্যালেঞ্জেস ফেস করেছি। আর এমনও ফ্যামিলি পেয়েছি যারা আমার সাথে খারাপ ব্যবহার করেছে, কিন্তু আমি তাদেরকে সবকিছু বুঝে সেটাকে সর্ট আউট করেছি। তো আর বেশিরভাগ পেশেন্ট ফ্যামিলি তারা এটাই জানে যে ক্যান্সারটা শুলেই ছড়িয়ে যায়, তো সমাজে হলে তারা ভাবে। সেটাকে আমি ব্রেক করার চেষ্টা করেছি যাতে তারা জিনিসটা বুঝতে পারে। তারা ঠিকঠাক মেডিসিনও পেশেন্টকে দিতে পারতো না, পেশেন্ট নিজেও ঠিকঠাক মেডিসিন খেতে পারতেন না। আর তারা সাইকোলজিক্যালিও ডিস্ট্রেসে ছিল পেশেন্ট আর পেশেন্ট ফ্যামিলি। তারা পেশেন্টকে নিয়ে খুবই বিরক্তি বোধ করতো, এবং কিভাবে তারা পেশেন্টের সাপোর্ট দেবে তারা সেটা জানতো না। তাদের টাকা পয়সারও প্রবলেম ছিল, আর কিভাবে তারা পেশেন্টকে নিয়ে আসবে ক্যান্সার সেন্টারে সেটাও তারা বুঝতে পারতো না। তাদের আশেপাশে কোনো লোকাল হেলথ কেয়ার সেন্টারও ছিল না, মেডিসিনটা কিভাবে তারা সংগ্রহ করবে সেই হিসাবে তারা বুঝতেও পারতো না। নেক্সট স্লাইড প্লিজ।
Next slide, please.
তো আমি পেশেন্টের এইরকম পেশেন্টদের আমি যেভাবে হেল্প করেছি, প্রোভাইডেড নিড বেসড সার্ভিস, তারা কি চায়, তাদের কি পেলে তারা খুশি হবে, সেদিক দিয়ে আমি দেখার চেষ্টা করেছি। যেরকম পেশেন্ট যদি আমাকে কল করে তাহলে সে টাইমলি সেই কলটাকে উঠিয়ে পেশেন্ট কিংবা পেশেন্টের কেয়ার গিভারের কল আমি উঠিয়ে তাদেরকে টাইমলি তাদের যে সিমটমস, তাদের যে প্রবলেম, সেটা আমি সলভ করার চেষ্টা করেছি। মেডিসিন এবং প্রেসক্রিপশন সেগুলো আমি টাইমলি পৌঁছে দেওয়ার চেষ্টা করেছি। আর পেশেন্টকে নিয়ে লোকাল হসপিটালে গিয়েছি, আর পেশেন্টের লোকাল ডাক্তারের সাথে যোগাযোগও করিয়ে দিয়েছি আমি। আর আমি পেশেন্ট আর পেশেন্টের ফ্যামিলি যাতে আমার উপর ট্রাস্ট করে, যাতে আমার কেয়ারটা ওরা নেয়, সেদিক দিয়েও আমি তাদের সাহায্য করেছি। তারা আমার কেয়ারটা নিয়েছে, তারা আমার কেয়ারটা পেয়ে খুবই খুশি। আর আমি এই সবগুলো শিখেছি টাটা মেডিকেল সেন্টার ওয়ার্ড থেকে, প্যালিয়েটিভ ওয়ার্ড থেকে। কনসালটেন্ট যখন রাউন্ডে আসতেন, ডক্টররা যখন রাউন্ডে আসতেন, তখন তাদের কাছ থেকে আমি কিভাবে পেশেন্টের কেয়ার নিতে হবে, কিভাবে মেডিসিন তাদেরকে বলতে হবে, এবং মেডিসিন কি জন্য নেবে সেটাও বলতে হবে। তো সেদিক দিয়ে আমি সবকিছু শিখেছি। আর বেসিক নার্সিং কেয়ার, কিভাবে পেশেন্টের নার্সিং কেয়ারটা আমি দিতে পারবো, সেটা আমি ওয়ার্ড নার্সের থেকে শিখেছি। নেক্সট স্লাইড প্লিজ।
Next slide.
তো আমি এই হোম বেসড কেয়ার থেকে কি কি শিখলাম। তো পেশেন্ট অ্যাসেসমেন্ট, কিভাবে পেশেন্টকে অ্যাসেস করতে হবে, পেশেন্টের সিমটমস গুলো কিভাবে ম্যানেজ করতে হবে, পেশেন্ট কাউন্সিলিং, পেশেন্ট যে তার এন্ড অফ লাইফ কেয়ার কি তার বেস্ট সাপোর্টিভ কেয়ার, সেটা নিয়ে পেশেন্টের যে প্রবলেম আছে, পেশেন্টের যে সাইকোলজিক্যালি প্রবলেম আছে, সেই দিক দিয়ে আমি কাউন্সিলিং করেছি। পেশেন্টের কোয়ালিটি অফ লাইফ কিভাবে ইমপ্রুভ হয় সেদিক দিয়েও আমি পেশেন্টকে হেল্প করেছি। এবং তাদের যে প্যালিয়েটিভ কেয়ার, তাদের যে অ্যাডভান্স ক্যান্সার, তারা সেই বিষয়ে জানতো না, সেদিক দিয়েও আমি তাদেরকে বুঝিয়েছি। তো এবং তারা কিভাবে ডে টু ডে কোয়ালিটি অফ লাইফ তাদের ইমপ্রুভ হবে, তারা কিভাবে সুস্থ থাকতে পারবে, সেদিক দিয়েও আমি তাদের সাহায্য করেছি। আর পেশেন্টের কেয়ার গিভার কিভাবে পেশেন্টকে কেয়ার দেবে এবং পেশেন্ট কিভাবে নিজের কেয়ার নেবে, সেদিক দিয়ে আমি তাদের হেল্প করেছি। তারা ঠিকঠাক কেয়ার নিয়েছে, এটা আমি তাদের কাছ থেকে শিখতে পেরেছি। আর এই প্যালিয়েটিভ কেয়ার থেকে আমার অনেক নলেজ এসছে পেশেন্ট সম্পর্কে। আর এই হোম বেসড প্যালিয়েটিভ কেয়ার, যে হসপিটালে যদি একটা পেশেন্ট থাকে সে কিরকম কেয়ার পাচ্ছে, আর আমি বাড়িতে গিয়ে কেয়ার দিচ্ছি, হসপিটালে একটা পেশেন্ট কেমন থাকছে, বাড়িতে কেমন থাকছে, তো এটা আমরা অ্যানালাইজ করে দেখেছি। তো পেশেন্ট বাড়িতে খুবই ভালো থাকছে প্যালিয়েটিভ কেয়ারটা দেওয়ার কারণে। এবং লোকাল হেলথ কেয়ার যাতে পেশেন্ট যাতে ইন কেস অফ এমার্জেন্সি লোকাল হেলথ কেয়ারদের সাথে যোগাযোগ করতে পারে এবং লোকাল ডক্টর লোকাল হসপিটালের সাথে যোগাযোগ করতে পারে, সেগুলো আমি করে দিয়েছি। তো সেদিক দিয়েও আমার একটা এক্সপিরিয়েন্স হয়েছে। আর পেশেন্ট বেশিরভাগ ক্যান্সার পেশেন্ট তারা অ্যাডভান্স কেয়ারটা নিতে পারে না, তো অ্যাডভান্স কেয়ার দিয়েছি তারা অ্যাডভান্স কেয়ারে এসে তাদের কোয়ালিটি অফ লাইফ ইমপ্রুভ হয়েছে। তো সেই দিক দিয়েও আমার এক্সপিরিয়েন্স হয়েছে। থ্যাংক ইউ এভরিওয়ান।
Next slide, please. Greetings, everyone. I'm Dr. Gaurav Kumar. I'm a consultant in palliative care, and I would just talk very crisply about the insights and experiences from a clinician point of view. Next slide, please. So my colleagues have explained as to what we are working on, and this slide actually showcases the challenges that we actually faced while doing this work of delivery of palliative care at the home of the patient. Now, I have divided this into 4 domains of the personal level. Like what we felt was that there was reduced awareness not only among the patient, but also amongst the healthcare providers in the community regarding availability of palliative care to optimally control symptoms. Now, there was a notion that we felt that in the public that advanced cancer patients, by default, they suffer a lot of pain and they have a lot of high symptom burden. So there was reduced awareness that there is palliative care which can actually help them in improving the quality of life. Now, what we tried to do was educate the community health providers in reducing the gaps, and not only the community healthcare providers, but also the doctors and the nurses in the community, that through training we try to improve their knowledge about advanced cancer care and palliative care, and this way we try to reduce the gap to some extent. Now, on a health system level, we felt that there was inadequate prioritization of symptoms. That was also related to the knowledge gap that we felt. For example, a patient having shortness of breath because of pleural effusion in a metastatic cancer. Now, for the patient, the care provider to actually come to the conclusion that there could be fluid in the lungs, it took a lot of time. And so timely intervention at the first instance itself was delayed, which leads to more complications and increased suffering for the patients, and not only the patients but also the providers. Then from the system level, we also face challenges with regards to opioids availability. Now, our country has stringent rules and regulations regarding availability, opioid storage and opioid dispensing. So because of those restrictions, there was a huge challenge that patients who actually require narcotics, opioids, they were not able to procure that. So through our intervention of the community health worker actually going home, we could close in the gaps to some extent. At the organizational level, we face challenges with regards to limited infrastructure at the community, in terms that basic facilities like, even the vitals monitoring and basic blood tests or some basic procedures were not available because of the limited infrastructure in the rural areas. There was a huge gap between the demand and supply, of course, with the number of cancer patients increasing in our country. The number of providers to treat and to care for those patients was too less. And from the policy level, we felt that India, majority of the Indians living in the rural India, they don't have insurance, health insurance. Now, the government provides some public funds for them, but majority of the funds were exhausted in the diagnosis and the early treatment. And by the time they come to palliative care, they are not left with much fund, and that led to a lot of financial toxicities. And also we found that there is because of fragmented legislation with regards to end-of-life care and advanced care planning, we felt that patients faced difficulties with regards to having a dignified and a comfortable end-of-life care. Next slide, please.
It's not going. I don't know what happened. Okay.
Yeah, so I'll just summarize the core findings that we felt from a clinician endpoint was that a majority of the patients that we had came at late stage of the disease. It would be stage 3 or stage 4. Now that was because of reduced awareness, reduced screening, and the reduced programs, means the programs not reaching the population, target population. And because of that, the symptom burden would be huge. That would be a huge challenge for palliative care physicians. And symptom burden not only in the terms of physical symptoms like pain, nausea, vomiting, cough, anorexia, but also psychosocial symptoms like patients would be very low and depressed, and that would affect the quality of life. And also we found that there was spiritual pain in the sense that, you know, they would be diagnosed at the last stage of their disease and with not much anti-cancer treatment available. So that would lead to a lot of existential and spiritual distress, which we encountered while we were conducting our study. Now, a few points that I felt that was contributing to these was reduced awareness in public that I discussed, the low literacy levels, workforce deficits. There is a huge gap between the providers and the people who require their help. Poverty, the financial toxicity that patients have, which actually deters them from coming to a hospital at the right time early during the stage, and the social stigma, of course, that cancer carries a huge social stigma in our country, and people in the rural settings, they are kind of afraid that if they are diagnosed with cancer, maybe the social interaction and people would stop coming to their house, people would stop caring for them, and of course, insufficient access to care and medications. Next slide, please. Now, how do we look forward to it? Now, there is a need for new models of cost-effective community-based palliative care, which would benefit the patients and the population at large, and there would be a smooth flow of care between the providers and the patients. And there is a need to reduce gap in service provision through good quality research. And for that, we need more funding. And there is a need to raise awareness, not only amongst public, but also awareness and education amongst the healthcare providers to reduce the phobia which is associated with opioids, with advanced cancer and palliative care. Thank you.
Thank you very much. And I just wanted to end it with saying, like, everything that Dr. Gaurav mentioned, all the challenges, and those were real challenges, and our community health workers actually were able, they bridged that gap, and they were able to provide a lot of support in regards to those challenges. Thank you so much.
Thank you.
Wonderful, wonderful presentation. Thank you all so much for highlighting the experience of India, and I can attest to the fact that a lot of those experiences are also existing in similar settings. So thank you for that. So let me quickly move to our next presentation. And again, wanted to highlight for those of you who recently joined, the Slido still open with the word cloud. That is asking which words come to mind when you think about community health workers, patient navigators, and community-based participatory research in cancer. And we really are thankful for your responses. So our next and last presentation is coming from Rwanda. We have Dr. Tiones Maniragaba, who is the director of the cancer program at the Rwanda Biomedical Center. He's a clinical and radiation oncology consultant at the Rwanda Cancer Center of the Rwanda Military Hospital. Dr. Maniragaba is a lecturer at the University of Rwanda's College of Medicine and Health Sciences, School of Medicine and Pharmacy for the past 5 years. He has served as a consultant with the CAN project in Kigali, elaborating chemotherapy protocol in the city of Kigali and advocating for a cancer navigation program. And it will be highlighting patient navigation, the Rwanda experience. Dr. Maniragaba. I'm going to stop sharing, and if you can share your slides for us.
Good evening, everybody. Hello, morning.
We're so sorry, Terence, we can't see you on the screen.
You can't see me?
We cannot see you. The camera is just a dark screen, black screen.
Now you can see me?
No. We still cannot.
I was just to share the presentation.
No problem.
Do you see it?
We see your presentation, but we cannot see you on camera. But if we, probably in the interest of time, we can go ahead and have you start your presentation.
I don't know what to do, but my camera is on. But I think I can present, sorry.
No problem. Thank you.
So, as you can see, thank you, Hawa Kamara, for a good introduction. I would just like to present my apologies. So because I delayed, we here in Rwanda, we are preparing our 2024-2025 action plan. And you have to understand that I am new in the program because since last years, as you have presented, my job was just about teaching and also doing some clinics. But this time, since 3 months, I'm in the program for the whole country. So I had to be busy with others for the whole health sector to make sure that I gather all is necessary for our cancer control plan in Rwanda, including, this thing that we are talking about now, detection, awareness, treatment, survivorship, research, and all those projects put together, all infrastructures that is needed and logistics to make sure that we help Rwandans. So this is this is my title as I have presented myself, and this is the gorilla that you can see showing the good welcome for all you guys who are interested to come to the Central and East Africa in Rwanda, whereby we have gorillas. We'll be happy to welcome you. So my presentation here is just talk about patient navigation, the Rwandan experience that you have been having since 2019 in Rwanda. And this is me. I have interested, Kamara has introduced myself. So what we know is that cancer navigation has been proved to be the sole methodology in low and middle income countries to improve data and quality cancer care to achieve cancer control plan. We have found that it helps in improving health system delays to shift from local advanced disease at treatment centers to early stages, hence curative management. And also, we have seen through the study and programs run here that it improves, enhances treatment guidelines and improves also cost effectiveness in multidisciplinary care, but also it improves psychosocial care and survivorship cancer patient and also other advantages. So here I'm going just to share our experience. Talking about 2 projects we ran here. One that was like a cancer navigation between. Hello, can you hear me? Hello.
Yeah, we can hear you.
Thank you so much.
Yes.
So
And
I'll
can
be
you
talking about 2 same projects that were run in the same time. One was about cancer navigation between the treatment centers, which we namely like interoperability. The second was community mobilization and linkage to care in Rwanda. So we know in Rwanda, the way the healthcare system is, we have like at the top, we have the teaching hospitals, and then follow with some referral hospitals. That's the link, the top leadership. And then you have district hospitals, which is, near to the community between the teaching and the district hospitals. And then you have health centers and health posts, which are in the community. So, at each level, there are, packages that should be delivered. We know that more than 8% of our patients are managed in the community. So in the community, that's where now nurses and general practitioners are caring for patients for common diseases like infectious diseases and awareness and screening for NCDs. So cancer care in Rwanda has been lagging behind since like 10 years when the government of Rwanda embarked on cancer control plan. And we set by control plan showing what we should be doing in awareness and screening, what we could do in treatment and survivorship and cancer research. However, due to low resources, especially oncologists, pathologists, and even a multidisciplinary care team that includes radiologists, medical oncologists, surgeons, we were still lagging behind. But through the the political will and the advocacy, advisory role of WHO, some strategies have been put. Among them, we have a surgical cancer elimination plan. We have breast cancer initiative that was being launched recently by WHO. We have also now the initiative of treat all in pediatric cases, but also we have, the government strategy to make sure that all cancer diseases are treated. The issue was the lack of awareness in our community due to socio-economic, socio-cultural economic issues. So most of our patients don't know what is cancer. And for those who know, sometimes our healthcare professionals in the community don't know. So people will be developing signs and symptoms which are not known, and then they will be managed like a simple disease in the community. They delay in their community, and then when it is when the diseases are advanced, that's the time now they refer them to the treatment centers. In order to deal with this issue in our health system, we produced one program of community mobilization, and we do like a campaigns. We do screening, especially this project was aiming to cervical and breast cancer, which prime the first one in prevalence, incidence, and morbidity in Rwanda, according to our cancer registry. So breast cancer and cervical cancer, they are the first one for the prostate. And then we don't have the same multidisciplinary cancer treatment in the same institutions. Remembering that we have in Kigali, radiotherapy, that's why I have radiotherapy, that's why I have chemotherapy, unless Partners in Health, which has one center in northern area, which requires like 3 hours to reach in Kigali. So, for example, someone who has breast cancer or cervical cancer, you can't find like a surgery, chemotherapy, radiotherapy in one center. You will find that one patient needs to circulate in different centers. Or because of all those previous socioeconomic factors I told you, we don't sometimes patients get lagging between two institutions. So we instituted a program whereby we made like a software which would be putting together all those institutions, and the navigator who will be now following the patient throughout the software to make sure that patient, if they finish chemotherapy, they join the radiotherapy timely, and they, doctors don't miss them, and also they can see what has been doing, what has been done in the previous institutions. So that's what was the program. Here now, I want just to start by talking about the navigation in treatment centers to improve multidisciplinary care. So this was the program in which we ran since 2018 in partnership with Sweet Cancer Challenge and its partners. So here I'm showing just the patient talking with the navigator. Here it is in the Butaro Cancer Center, which is northern area. This patient was suffering from breast cancer, and she was done with surgery and chemotherapy. And then to get radiotherapy, the patient needed to travel from northern province to Kigali. Because of lack of awareness, socioeconomic status, the Butaro Cancer Center of Excellence, through Partners in Health, they supported them in ticket and some logistics. But because of lack of knowledge, they may delay. And you know that to treat cancer, especially for adjuvant treatment, you have to wait between 4 to 6 weeks. So the navigator will be from Butaro will be collaborating with the navigator from Rwanda Cancer Center to make sure that the patient reach at Rwanda Cancer Center timely and then be treated. This project helped us just to improve the treatment guidelines, and also it helps just to improve the waiting time. It helps the patients also, for good outcome. So here I am showing the picture that the Minister of Health, the then Minister of Health, who is the Minister of State, and the collaborators, institutions, were inaugurating this project, and then we launched it in 2018. You can find the Minister of Health, Rwanda Biomedical Center, and its partners, especially Cancer City Cancer Challenge. Before we implement the project, we did the situation analysis report, and then we did like activity plan summary in the city of Kigali. 32 institutions participated in Rwanda to show the gaps which were there, and 126 health professionals participated, and we also include the 8 patients to tell us what was the gap. And the gap was that there were issues between the interoperability between institutions which treat cancer. Then patient navigation identified as key solution cancer for cancer care for cancer care delivery in Rwanda. These are the challenges that were shown among the ones that I have told you. Then we instituted the software which was called Join, which was instituted in Butaro Cancer Center of Excellence, Kigali University Teaching Hospital, Rwanda Cancer Center, which is part of Rwanda Military Hospital, and then King Faisal Hospital, and then we put also a navigator in the southern area where the University of Rwanda is based, especially School of Medicine, another navigator. So we will be having 5 navigators using the same system, so that whenever there is a patient suffering from cervical and breast cancer, they will be just directly picked in the system, and then navigators will be communicating between themselves and communicating with the patient. So this gives good result. Gave good result. These were the partners that I'm showing you, and key project advancement is that 1,354 patients benefit from the services, and then 60 registered on the platform. 5 centers participated all. These were the meeting that we ran just to agree on the way forward, how we'll be working together. They were like capacity development. We have conducted training between healthcare care professionals, radiologists, surgeons, radiation technicians, medical physicists, oncology nurses, radiation oncologists, all to understand the project and what it aims on, so that we'll be now working with the navigators. Achievement is that the treatment to initiate, the time to initiate treatment was decreased. We came from 90 days, which now, the treatment initiated in less than 90 came from 92, it went to 69. The treatment that was between 90 to 180, it came from 15 to 14. Now, also, we found that in 180, for those patients whom were getting treatment beyond 180 days, they came from 18% to 16%. In general, this study showed that it can improve time to initiate treatment, and also most patients abide on treatment. So this was the first project about the interoperability, just software used with navigators. The community mobilization, because there were 2 issues. First of all, navigation between treatment centers, but also there is health system delay where patients coming from the community, health centers to these hospitals, and referral with university teaching hospitals will take longer. A patient is having like breast cancer stage 1 in health center, but to come from health center to reach at university teaching hospital, it will take like 1 year, and then patient will be presenting at stage 4 diseases. At stage 4 disease, you can't treat curatively. The only intention of treatment will be palliative. How to change this? We made sure that we did like a study in one district of Kigali, whereby we did like a campaign from the communities, villages. All patients will be now received at health centers. We do now tests. We do like ultrasound. For those whom we found that they're suspected, there were navigators at every center. We transfer them directly to Rwanda Military Hospital, which is harboring, the Rwanda Cancer Center. They do pathology. Then after confirming that,
Sorry, Theonest, we lost you. It seems like we.
80, this is the partnership that we did between Rwanda.
I'm so sorry, Theonest. We just lost you for quite a few seconds, but you can go ahead. You can continue. Thank you.
Yes, okay. I was now talking the achievement that was made during this community mobilization in the community to link them to care. We took patients in every health center. We did teaching, we did ultrasound, and then HPV between combined program, cervical cancer and breast cancer. For all patients that we find that they have like a BRF4, which is like a testing tool that we make to make suspicion of breast cancer, we will directly link them to treatment centers, which is Rwanda Military Hospital. For them, we found that they have precancerous lesion, we treated them. For those we found that they have like suspected, malignancy on cervical cancer, we transfer directly to the treatment centers. We found that 75% that were presenting at treatment centers with locally advanced disease could be shifted now to present at treatment centers at other diseases, whereby they can be treated with curative intention rather than palliative intention. And with this now method, we found that if we have navigators in the community at these hospitals and navigators in treatment centers, because we know that all treatment modalities are not in the same treatment center, we can shift from these late presentations and even observe the guideline whereby patients will get at treatment centers at early stage and also get treated observing the treatment guideline. And because our number of patients, most of them, they are at young age, they can be treated, cured, returned back in their community, keep contributing to the family life and economy. Generally, this is what we are finding like 1, 2, and a very good commitment. This is what I'm showing. I have told you about the objective of the study, the activities that we have done. I've talked about it. This was the meeting, and this is what we have achieved during this community mobilization and linkage to care. We found that we can change, we can shift from the late presentation at early stage. We can make sure that we observe the treatment between treatment centers. This, Kamara, we have recommended this evidence to the government of Rwanda, and the good news is that this evidence has been considered. Now we have got a grant to make sure that in this hospital in Rwanda, we'll be having a navigator and at treatment centers, whereby all patients that will be treated, suspected for cancer, they will need directly to be channeled to treatment centers just in 1 month to be treated, and then, if possible, they turn back to their community. Thank you for attending. The lesson we learned: we can't achieve this without partnership. All this we have done, it was through the partners that we work together in treatment. There is JICA, there was Roche, there were MSD, Sanofi Icon. We thank them. We are also, to make sure that we sustain this project. There is a sustainability advocacy for institutionalization. I have told you that the government of Rwanda, through the project that we have got, the partnership, the grant, we are now taking over the project for 2 years, but also we want to expand it through whole districts because we did it in one district. And also we want to speed up the strategic plan to include all this in the government, human resource. And then we are publishing in Global Oncology the evidence for this study. Thank you so much. And I hope that the attendees can, extrapolate this in their program. Thank you so much.
Thank you very much, Theonest, for this great example from Rwanda. And wanted to apologize for the audio issues during the presentation, and we want to thank everybody for your patients as we are navigating those technical realities in this new virtual world. So next up, we are done with those great presentations. Thank you to all the speakers already. And now this is the exciting part as well. We're now going to move to our Q&A session, where you will all be able to ask questions to our panelists. And we see that there are already a few questions in the chat, but please feel free to send us your questions. We have about 20 minutes, so we'll try our best to answer the ones we have, and we also have a few others for you all. And I want to welcome my colleague, Jack. Thank you very much for being here. And on the screen, we have our speakers. And I want to quickly go back to our word cloud, which a lot of you have responded to. Thank you for that. Jack, take it away.
Great. Yeah, Hawa, thank you for introducing everyone. And it's a pleasure to be here working with you all. So I was watching, I have the word cloud developing on the side while the presentations were being done. And as you all can see now, there's a real cluster around this theme of being essential. You see the word essential, there's essential and overlooked, there's extremely important. And I think that arose from everyone's presentation. I remember Dr. Ocampo talking about raising awareness about the great work that patient navigators and community health workers are doing. And also Dr. Kumar said similar things. So I wanted to, I'll put this question first to Dr. Ocampo, but then we can open it to everyone. How do you collaborate, or how do you see working with health policymakers to make the essential nature of patient navigators more obvious, to clarify their importance and perhaps to establish their importance as a routine part of cancer care?
Bueno, buenas aquí de nuevo. Lo más importante es establecer esos enlaces, ¿verdad?, con los tomadores de decisiones, porque yo creo que siempre es importante tomar en cuenta las opiniones de estos grandes funcionarios, como lo son los trabajadores sociales comunitarios y los pacientes, los navegadores de pacientes. El fin de semana pasado asistí a un congreso de neoplasias anales. El broche de oro fue cerrar la sesión con los pacientes, lo cual me pareció una idea muy buena. Entre estos pacientes, el denominador común entre ellos fue que a ellos les hubiera gustado tener mayor educación sobre qué iba a pasar después de que recibieran quimio y radioterapia. Entonces yo creo que es muy importante no quedarse solo en la parte clínica, sino también tomar las opiniones de estos funcionarios tan importantes para poder desarrollar las mejores políticas en salud que sean accesibles y que sean entendibles en todo el sentido.
Yes, thank you for that. And Dr. Suparna or Dr. Gaurav, do you have any thoughts similarly for the situation in India and how you can communicate the essential nature of community health workers to perhaps health policymakers?
Yes.
Yeah.
And I'll let Dr. Gaurav speak on that because he has a better idea in India.
Yeah. So basically, essential is the word I would say that, and it has come out here also. And because I think globally we are moving towards decentralization of healthcare, that and COVID has taught us more of that. That how we can actually help patients not coming to the hospital and coming only in times of their dire needs. And in terms of collaborating with the policymakers, we already have something in lineup where the government agencies are also following a community health officer program where they're training and putting their officers into the community to provide this kind of care. So, somehow creating a model and showing the success of the model and disseminating the information to the officials and the policymakers would help in amalgamating both the models together so that we come to a final conclusive best model that would work for everyone. So that is what we are trying to achieve. Shubhana,
Yes.
you may add to
Yes.
something.
Right. And, I actually want to add on to what Dr. Gaurav said. That was absolutely a few things I feel that are like extremely important in getting this essential piece. They are essential, but how do we communicate that to our policymakers? In order to do that, number one is we have to generate that evidence, because all the policymakers need to see evidence that this model is successful, or whatever model we are trying to say is essential is successful, and there has to be evidence backing it. And that's what we are trying to do through research, is that we are trying to find that evidence and then kind of make our policymakers buy into it, and so that they see the importance of this and then can move forward. So I think that is what is needed. So that's why we fit like this. The research part is also so important, as well as not just research, even in practice. If you can generate that evidence for the policymakers to understand, show them how we are successful, how the model is successful, and that would help them to make those decisions on policy.
Brilliant, thank you. And I think a related thing I saw is, so we just had a question in the chat from Montserrat about saying patient navigators are underpaid and overworked. And that statement has certainly showed up in this word cloud as well. We see essential and overlooked, we've seen invisible, we've seen under-resourced. And so what might some strategies to incentivize or avoid burnout be for these essential workers? Dr. Maniragaba, would you like to answer that first? I don't know if you can hear me.
Yeah, he might have dropped off. I will check on him real quick, but we can probably.
Okay, no trouble. Could somebody else on the panel answer that question, please? Feel free to call out at this point.
I can start.
Please.
From our experience, what we have seen, you are absolutely correct. A few things that is for any workforce, whether it's like community health workers or whether it's anyone, for any workforce, in order to feel, to avoid burnout, of course, you can't decrease the workload. I think that's like, because if you have to go and help the community, that is going to be there. But on the other side, like, a few things I would say. One is to educate them and educate our health workers and, show them, kind of let them know what is expected, have that expectations in there. And the second I feel is very important is appreciation. And that is in general for any human being. Like if your work is appreciated, then that really helps you to feel that belonging and want to do that work more, which I think I saw that in Chinmay. I have seen that, and he's so invested, and Chinmay can speak to this. But I feel that, the way our team is, and we have been able to appreciate all his work, that makes him feel and be able to do that work. That's one of the, and then the other part of it is that because Chinmay's work we have seen is extremely taxing, to be able to go, like he has spent late nights and he has been like spent days traveling through those waters to go into those communities. So it has been but the fact that, first of all, it is rewarding for him also to be when he comes to do the work and help the people, but it can get challenging. And that's when this support system at the back of him from the team is very helpful, I would say.
Yeah, I would just add one sentence. Suparna has mentioned almost all the things. There is a personal sense of fulfillment that the community health workers acquire serving in their own community. So the kind of accomplishment and happiness that is one thing which, and of course, support and motivation. In cancer care, I think everybody faces this issue of burnout. So with a good support system and continuous motivating, and that actually helps them, overcome the burnout thing. Yeah.
Yes, thank you all. Before we move to our next Slido question, Dr. Ocampo, would you like to speak to the issue of incentivizing patient navigators or preventing burnout among your community health workers?
Claro, concuerdo totalmente con mis compañeros. Hay diferentes formas, no tienen que ser monetarias como uno los puede incentivar, ¿verdad? Yo creo que una parte medular es el reconocimiento y agradecimiento. Como lo expliqué en mi presentación, hay que hacerlos sentir que forman parte de algo importante y que en realidad su trabajo es muy importante. Sin el trabajo de ellos no tendríamos los resultados que tenemos ahorita. Para nuestra organización, los trabajadores de campo son sumamente valorados porque son nuestra carta de presentación a la comunidad y en realidad ellos son los que están impactando positivamente la vida de otras personas. Entonces yo creo que hay que brindarles mucho apoyo, hay que hacerles reuniones, reconocerles el trabajo, valorarlos, darles flexibilidad laboral, entre otras cosas.
Yes, I think that concept of having a team behind you, that making the support obvious is of course immensely important in any field of work. Hawa, would you take us to our next Slido question, please?
Yes, actually, Jack,
I might be able to do it.
that in the interest of time, we do have a few questions in the chat that I wanted to address. Yes.
Yeah,
and thank you. All of you who have sent out questions. So the first one, I wanted to go back to our executive director from the Need Cancer Foundation. And he has his first question, which is how can organizations like ours, the Need Cancer Foundation, collaborate to enhance the impact of community health workers in LMICs? And we just maybe a minute per person, per team, and then we'll get to the next question. Thank you. Maybe we can have Theonest. I know you were having some connectivity issues. Thank you for joining us back. If you want to start with your response. Thank you.
I'm here. Can you come back just to your question, sorry?
Sure. So the question is from Dr. Bakwatanisa, and I'm sorry if I'm not pronouncing this correctly, who's from the Need Cancer Foundation. And his first question is, how can organizations like ours collaborate to enhance the impact of community health workers in LMICs?
Yeah, thank you. First of all, just to inform that since more than 15 years, the government of Rwanda has embarked on the institutionalizing community health workers to be part, to be like the pillar of disease control in Rwanda. To inform you that Rwanda has, achieved the MDGs and even continue with the SDGs, especially in infectious disease control, like malaria, maternal health, and maternal health, through the collaboration and the very good integrated system whereby community health workers, are the pillars which help, the navigation of patients in those programs. So, because we have learned that through those programs, in NCDs also, we are trying to make sure that we incorporate NCDs package by increasing the number of community health workers in each village. We start by one health, community health workers, which were dealing like maternal and child health. They increased to make the second dealing with infectious disease. This time we are seeing if we can maybe propose the third, who will be working with the navigators from health centers and DH to make sure that we, for every patient who is suspected to have cancer, they are channeled very well so that they reach at treatment centers at early stage and then get treated. However, there's an issue of incentives, but also knowledge. So it is a program that may take like years. Taking experience from ours, just because of the political will and the very good commitment from our government, since we have seen the good evidence that navigation can be the first, achievement in achieving these issues, we are starting by 2 years, first of all, institutionalizing cancer navigators. And from there now we'll expand and extrapolate in all districts, and then health centers, then you go downward in community health workers. But obstacles are there. We need just to train people to have some knowledge, and then incentives, because it is a very huge work, very huge workload. But I'm sure learning from the previous experience of infectious disease through NCDs also will achieve it. Thank you.
Great.
So much.
Thank you very much. Maybe we can have Chinmi or Kanungo just quickly give their response.
So, organizations, I think the question was, how can organizations like ours collaborate to enhance the impact of community health workers? So first of all, depending upon the organization, if you are already have community health workers who you are sending out to the community, then the most important thing to do is to look for trainings that would impact the areas that you are working with. If it is maternal child care, if it is palliative care, if it is whatever you want to expand your work in, to provide those training, to arrange for those training. And then the second way to do it is that to collaborate. So you probably have to collaborate with some of your I don't know, in your area, local hospitals, which provide training, government organizations that provide training to give those training. And then once you have those, once you can enhance those training, then you can increase your impact by sending those community health workers in the areas that are needed the most. You can, so the areas some areas might need more maternal child health care, and you target your trained community health workers trained in maternal child care to those areas. Some areas, if you have a palliative care, and you have trained palliative care community health workers, then you send them to that area of designated areas to work with. So I don't know whether I answered the question correctly or not, but that's what I feel.
No, that's great. Thank you so much, Suparna. And in the interest of time, we have about 3 minutes. Just wanted to, I know we have a few more questions, but and we're sorry, we're not going to be able to get through all of them. But we want to thank you all for your interest and really your engagement. But one question that I wanted to finish this with is, Donna O'Brien is asking, can you say a bit more about what the comprehensive training with community health workers to provide palliative care includes? She found that very impressive for improving access.
I can start and then Gaurav can join in. I would have to say that truly this training had multiple parts to it. So we had to have a robust training that would include not only a didactic training, but also we covered all areas. We gave them basic palliative care training. We gave them symptoms, because just palliative care would not work. So they had to have the understanding of the symptoms. They had to have understanding of the psychological parts of palliative care. So all of that was covered in didactic. Then what we had done is that they had field training. They had case studies those are all taken from the WHO toolkit. WHO has a wonderful resource, WHO and WHPCA palliative care. They have a wonderful resource, a toolkit that is so wonderful for training community health workers in low resource settings. So we took a lot of the training from there and then delivered it. Then we did case scenarios, case studies, role plays. All of them were also part of the WHO toolkit. And then we, of course, did some cultural tailoring to the areas that we were doing. And another most important, what we found is it's not really like a booster training, but it's a continuous training, which we found very impactful, which was Dr. Gaurav's idea, is to have our community health workers, while they are doing in the field, also be engaged in the clinic, where they would work in the palliative care unit alongside the nurses and the clinicians. And that gave that that experiential training, which was extremely helpful, I feel. And Gaurav, you can expand more.
Do we have time for that?
30
1
seconds.
minute, I think.
30
1
seconds.
minute.
Okay, so yeah, basically we started, with the healthcare workers, they didn't have much experience with the cancer oncology section. So we started with basic oncology training, and then, the psychological component was very important. We had role plays in a number of scenarios where they actually experienced, how to handle difficult scenarios. We had hands-on experience in our wards. So that was a kind of a continuous clinical training that these community health workers would have. And in between the field visits, they would come to the clinics, and then, we would discuss. And so continuous support actually gave them a lot of confidence in handling the patients at home. So just a short, clinical experience and exposure I felt was most important in them handling the patients at home.
Absolutely.
Wonderful. That's a great way to end our Q&A. And we are on time, actually a minute over. I want to thank everybody for not only being here, for engaging and participating. I want to thank our speakers for the wonderful presentation and all the work, my colleagues for all the behind the scenes work. And one thing that we've seen through this word cloud is how essential community health workers and patient navigators are to cancer care. And I wanted to also point out there's a smaller kind of term here that we see is invisible. And I want to thank you all for making them visible today. Thank you, everybody, and have a wonderful rest of the conference. Have a great week.
Thank you.
Bye-bye.
Thank you. Bye.